Good afternoon, everyone. Good afternoon. I am Matt Ewalt. I serve the Texas Tribune as Senior Director of Events and Live Journalism. Welcome to those joining us here in Dallas in person and those joining us online for our conversation today addressing young Texans' mental health needs. During and after the COVID-19 pandemic, families, educators, and advocates worried about the toll on children's mental health and the lack of access to care. Despite Texas's mental health workforce shortages being at crisis levels, communities are coming together to find innovative solutions to better address young Texans' mental health. Today, we will look to better understand the challenges facing our kids and how the state is investing in addressing the crisis. We'll explore the work being done in schools, healthcare, child welfare, and restorative justice systems, how we create systems that work alongside one another to support every child, and consider how families can best support their children. We are joined today by Sabrina Brown, pediatric psychiatrist at Children's Health Specialty Center, DeSoto, Tegan Henke, Senior VP of Community Systems Innovation at Meadows Mental Health Policy Institute, Laura Vogel, Director of Mental Health Services at Momentum Institute. And I should note, Tracy Brown, Executive Director of Mental Health Services for Dallas ISD, is unable to join us today, but representing Dallas ISD in her place is Deborah Purge, Special Program and Training Manager for Dallas ISD Mental Health Services. Our program will run an hour, with 45 minutes for conversation and 15 minutes for your questions. Here in Dallas, we will have this mic stand set up right over there for our in-person audience, and our virtual audience can submit their questions online at our Q&A portal at texastribune.org/ask. We are grateful for the support of our sponsors. Our major sponsors today are Texas Association of School Business Officials, Raise Your Hand Texas, and Methodist Health Care Ministries. We also want to thank our host sponsor, the Commit Partnership here at Pegasus Park. Though corporate sponsors and donors underwrite this event, they play no role in determining the content, speakers, or line of questioning. I'll also note that tomorrow is the last day of our spring member drive, and it's one of the times of the year when we at the Texas Tribune ask people who appreciate our events and our journalism if they'd make a donation to become a Texas Tribune member. Tribune members make everything we do possible, including our free public events like today's. To learn more and to become a member, visit texastribune.org/support. And quickly, I'd like to call attention to a couple upcoming events. On Tuesday, June 18th, we'll convene in Corpus Christi for a conversation on protecting Texas's coastline. And on Wednesday, June 6th, our next We the Texans event will be in Austin at our downtown studio, looking at government transparency and public access to information. You can find more information, including all of our speakers for these programs, at texastribune.org/events. And finally, tickets are now on sale for Texas's breakout politics and policy event, the Texas Tribune Festival, which returns to downtown Austin September 5th through 7th. Join us for 3 days of unforgettable conversations about the issues that matter to Texans at our annual celebration of big, bold ideas. You can purchase your tickets at tribfest.org. Now let's get to know our panel. Sabrina Brown is an assistant professor in the Department of Psychiatry at the University of Texas Southwestern Medical Center and child psychiatrist for Children's Health Behavioral Health Integration and Guidance Initiative. Laura Vogel is a licensed psychologist and director of mental health services at Momentum Institute with over 25 years of experience working with children and their families. And our moderator, Stephen Simpson, is a mental health reporter for the Texas Tribune, where he covers behavioral health in schools, treatment in the judicial system, substance abuse, and the state mental health system, among other topics. I also want to acknowledge Tegan Henke, Senior VP of Community Systems Innovation at Meadows Mental Health Policy Institute, and Deborah Purge, who has replaced Tracy Brown, who was unable to make it today. And again, Deborah Purge's title with Dallas ISD is Special Program and Training Manager for Dallas ISD Mental Health Services. And with that, I turn the program over to Stephen.
Thank you guys for having me. There's been a lot of studies done since the pandemic about the youth mental health situation, but I find that the most hands-on people will be able to explain this better for us. And I think that starts with our educators. And that's the reason I'm going to start this off with Deborah Purge over here. Sort of, could you explain what the mental health landscape looks like for our students?
Okay, thank you for that question. And so I think before I kind of answer that, I think a lot of people, when they're looking at mental health concerns among students or youth, they think that it's just now that the mental health crisis is just beginning. But the mental health crisis has been here long before COVID started. So if we look at the pre-pandemic numbers, the U.S. Surgeon General, Dr. Murthy, talks about that there are three numbers that actually really scares him. The first number is 36. And so if we look at high school students, 36% prior to the pandemic expressed persistent sadness and hopelessness. 57% represent the increase in the rate of suicide pre-pandemic. And then 11 represents the number of years from the time the child first experiences a symptom to receiving care. Those are some astounding number before pandemic. So there has been a mental health crisis pre-pandemic. I think what has happened now there's a greater access to service. During pandemic, we went virtual. During pandemic, there's no one in this audience or any one of the students that we serve that has not experienced some form of trauma, whether it's someone dying, a loss of job, isolation. So it has brought it to the surface. And so one of the things that you look at is the rate in suicide that was the second largest cause of death for our school-age students is now the leading cause after pandemic, right? And so in Dallas ISD, some of the things that we're seeing is our referral system, we're having anxiety, disruptive behavior, and depression. Before a few years back, it was anxiety, depression, and disruptive behavior. So, and as we go on and some more question, I'll give you guys an idea why you may be seeing more disruptive behavior, and is it truly willful disobedience and disruptive behavior, or is that trauma?
And would you agree with that statement, Laura?
Definitely. We have been seeing this increase prior to when we look at the rates compared to from like 2010 on. In that window of 2010 to 2015, we saw youth mental health skyrocket. And we all know like what was happening in that time period, right? Like smartphones became easy access. The market saturation was over 50%. The iPhone 4 was released that gave you the ability to turn the camera around and take a selfie. And iPhone was the first, but all the other producers as well followed suit. And so in that range from 2010 to 2015 especially, we began to see this increase in concerns from youth for youth mental health. The pandemic was an exclamation mark on that. We really began to see what we're seeing in our center is similar concerns, but they're more severe now. Yeah.
And for a lot of young people, their first contact for mental health treatment is the emergency room. And I guess from a medical standpoint for Sabrina Brown, what is this doing to the medical community?
Right. And I think that having your first brush with mental health treatment in the emergency room is very traumatic in a lot of ways, right? The emergency rooms aren't set up for really getting to a good environment for mental health treatment, right? They're set up to triage and treat medical emergencies and get, people in and to the next best place or, best placement. So There's a lot going on, and to be in that environment and for a lot of these kids disclosing for the first time some very deep rooted, very traumatic things, whether it be, like suicidal thoughts or they've been self-harming, it can really dissuade people from wanting to speak up in the future. I can't tell you how many times I've had kids come to see me after they've gone through the emergency room and been plugged into the system, and I'm talking to them about how they're feeling, and they tell me, I'm scared to tell you because I don't want to go back to that place. And so we really, on the medical side, have also seen exactly what you guys were saying, that before the pandemic, mental health was a problem. And I think it's so important to recognize that, because there can be part of us that says, oh, it got worse during the pandemic. Maybe it'll get better and things will settle down afterwards. And that's not the case. That's not what we're seeing. I think that it unmasked a lot of things, and we're going to be seeing the repercussions of that. But this was a problem before, and it's going to continue to be a problem after. And then just from the medical system standpoint, one of the things that we were seeing here in Dallas and then across the country is that kids were getting stuck essentially in the emergency room for mental health concerns because there just, wasn't anywhere for them to go. So they were waiting for a bed to open up at a behavioral health center. And so now it's not just that I'm in this emergency room in an emotional crisis and this isn't the best setting for me. Now I'm here for days on end. And now, that is really traumatic. And so in the work that I do, I work with primary care physicians and other primary care providers to try to close that gap between, like we said, the first symptom showing up and getting treatment, because the PCPs are the ones that are seeing the kids regularly. And so we really try to educate them on finding those early signs and getting them into treatment to hopefully avoid having the kid have that traumatic entrance into the mental health treatment arena.
And I guess at this point, there's no denying that there is a mental health crisis amongst our young people, but there's also seems to be a dropping stigma of the mental illness around these people as well. And so for Tegan, I guess this is a question of, is there more mentally aware generation causing these numbers to rise up, or is it kind of a combination of both?
Well, I'm not going to second guess the Surgeon General. So I'm going to say, yes, we are still in a mental health crisis, and that is a thing. But I do think that greater awareness does lead to more students and more young people acknowledging that they have a mental health need and seeking treatment. And so I think that overall is a good thing. So I think it's like a both and. We have a mental health crisis on our hands. And part of that crisis is because our systems aren't equipped to support the need of students and young people. They weren't equipped prior to the pandemic, as my fellow panelists have just described. And we're still not equipped to do it. We're working really hard and we're getting there, but we're not quite there yet. And so I see the rise in awareness and the reduction in stigma to a certain extent. There's still some stigma present. I see that as an opportunity for us to really design systems that are responsive to the students and the young people's needs, because they're telling us. So they're telling us what they need, and we need to listen.
And this will be a question for both of our educators here. I guess, what role do you see social media playing when it involves student mental health? Is it a help or is it a negative?
So for me, social media is like our panelist said here. In the past, you would have to wait until you see someone to be able to bully them or to influence them. Now social media brings it right there. This is this false sense of, oh, everything is perfect. And so, if everything's perfect, I want what you have. And what are you doing to get what you have? And so it gives, I think sometimes social media gives this false sense of security or good enough. And students that are already struggling with either self-esteem or trauma, they see something that is appealing. Social media, it's almost like taking a drug, right? So it stimulates the part of the brain that makes you feel good. I'm going to see how many hits I have, how many likes did I have, how many people looked at me. And if I'm in a place where I'm not feeling my best, this is going to help boost my feeling, but we know that that's temporary, right? That's just on the outside. It doesn't fix the things that are inside, that are deep behind what's below the iceberg. That's not being touched.
And I think with the increase in the use of social media, we have seen a generation start to be raised in a world that is virtually unsupervised by adults. We think we know what's going on as adults and caregivers. We don't. And so we've got very young children navigating a world with very little guidance. And then we also have children not doing as much free play, not interacting with each other in ways of, like the face to face in communities. When you think about a virtual community, if I am upset by it or I don't like what's going on, I can leave or I can block somebody. But when I was growing up in the community that I was in, if I had a disagreement with you, I had to figure out how to navigate that. Otherwise, I won't belong. I won't be part of this community. Our children are not learning those skills. And so when we think about mental health at a very root cause, that is contributing to some of the concerns. I know your question was kind of around like awareness of mental health symptoms and those sorts of things. And I think in some ways, social media for older kids can give them tools and help them find communities of support. But when we have younger and younger children having access to social media, it is, in my opinion, and a lot of researchers' opinions now, it is at the root cause of what is beginning to contribute to this crisis.
May I add something to that too? So I agree with all of the things that Dr. Purge and Dr. Vogel just shared. And I would say we also need to figure out what digital literacy looks like and what social media literacy looks like for young people, because I don't think it's going away. So, and we need to really support parents to know how and when to monitor their young people's use of technology. We know that there are, overuse leads to some anxiety. We've heard about these things. We've also heard of, like the predatory behaviors of some of the social media companies. And we just don't know the long-term outcomes around social media use and technology use in young people. Though, to y'all's point, we definitely know. Yes, exactly. And so I think I also want to reinforce that young people do find community online as well, and we don't want to lose that. So let's figure out the ways that we can support that community building, especially for young people who might be particularly isolated, and finding identity support online and through media in a healthy way.
And I just want to add to that, because I will say that talking about the idea of like digital literacy has become almost just part of my work in talking parents and kids through healthy behaviors and healthy activities in general. So that's just part of the conversation now. And I think that's something that, like you said, it's a reality. It's not going away. And it can be that double-edged sword, right? And then beyond just the social media aspect of, seeing on Instagram or I guess now it's TikTok. I'm officially like letting it slide past me. But I think as adults, we've all had the doom scrolling experience, right? Where we've got 24/7 access to all of the ills of the world, all of the crises, everything that's going on. It's overwhelming for us as adults, right? Imagine with the young child who doesn't have the brain development, the maturity, the understanding to really process and understand all of that. And so they have that, like you said, unsupervised, unfettered access to all of those things. And I've seen a lot of anxiety stemming. I have kids coming in and talking about these things that they're worried about. And on the one hand, I'm like, really proud of them. I'm like, you have such more cultural awareness and you're more tuned into what's going on in the world than I was at your age, but also I was, I guess, ignorant and happy, right? At a certain age I had no idea. And they're just so much more aware. And so it is really important to talk to families and parents about supervising, moderating, everything in moderation, right? But also giving that context of, okay, these are the things that you're going to be coming across. This is what's going on. And walking them through that can help decrease some of their anxiety.
And I do think this is where bigger systems can come into play, because it is hard for if I'm the lone parent who's trying to restrict, because my kid is like, everybody else has access and I'm going to be made fun of. And that's real, right? Everyone else does have access and they will get made fun of if they don't have it. And so that's where I think schools can come into play and have some of these collective actions where it's like, you're not the only parent who is now restricting. We're asking for everyone in the school to do this. We're putting our phones away during school hours. I think there's big systems that can help parents with some of those things.
And I think one of the things that I would say as well is parents we really have to stay ahead of keep up with our children, because once you get caught up, they change the wording, they change how you access everything. And I think because we're such a digital age, like you said, we have to continue to communicate with our children, because we have to find out what they're thinking, not so much as say, no, you can't do that, but let's talk about it. Because I remember when my daughter was younger, and as soon as I felt like she came to every disagreement prepared. She's already looked it up. So then it was my opportunity to say, okay, let's check the source. What is the agenda that this source? Where is this coming from? Is this credible? And I want her to talk, because I want to hear what she's thinking. And I think that's what we oftentimes it's used as a babysitter, and we're not talking as much, and we're not joining. So you don't have to always say no, but you do want to know what it is that they know, and then fill in those gaps. Because I'd rather fill in the gap than to have someone else who's misinformed to fill in the gap, because that's when our kids get led astray. And one of the things that we do in Dallas ISD is I'm in charge of the programs, mental health training programs that come out of the mental health services department. And our goal is not only to educate parents, but we have to educate teachers so that they understand what a mental health crisis or a mental health illness looks like, because sometimes it looks very different, and it may not be the mental health illness of the days before. We're talking about kids that are ODing on fentanyl, and these, they're bigger consequences. We talked about that you only need a tip of a pencil to take your life using fentanyl. So parents have to be educated, but teachers have to know where they're hiding these things. How are they getting them into the classroom? Because these kids are these days, they're smart, they're savvy, they're ahead of us.
And that kind of builds on sort of with my next question here, but a lot of organizations have kind of taken a role to help young people's mental health, including the schools or hospitals. But the main reason for that is because the mental health workforce is too small to meet the demand. And it doesn't seem like there's going to be any solution to that anytime soon. So I guess for Tegan, sort of, how did we get into this situation? And then for Brown afterwards, sort of, does this mean hospitals and primary care physicians are going to have to start taking up some of that burden?
How did we get into this situation? I feel like that's a conversation we should have over drinks. That's a big question. So, it's a couple things. I mean, one, we don't have really great career pathways that lead to behavioral health clinicians. And so one of the things that we really need to do to increase the behavioral health workforce is create those career pathways. We have that for other careers. Starting in high school, there are certifications you can complete, and then transition to community colleges where you can complete more certifications and continue on to achieve credentials and licensure in behavioral health or other fields. And we need to do the same thing for behavioral health. So one, I think we need some workforce studies that we could take a look at to help figure out where we can fill those gaps, and then work with and partner with our post-secondary institutions to create some of the credentials that we need to fill those gaps. So I think that's one important thing. But once we achieve and we have a workforce, what are we doing to retain that workforce? I think that's another piece that we're not focused on as much. We have people leaving the behavioral health field left and right at all levels of credentials. So what is leading to all of that burnout and turnover and the reasons that people don't want to stay? I was a clinician. I got my training as a therapist and did my early work doing crisis intervention for children and youth, often in emergency rooms, and burned out very quickly. And I didn't go into this work for the money or the glory. As you can see, there's not a lot. But but go in for passion, right? We want to make a difference in our communities. And we're losing that along the way. So what are employers doing to make sure that their workforce is healthy, that they're able to access the mental health supports that maybe they might need? What do our health plans look like? How are we supporting the workforce even within the context of what they're hearing on a day-to-day basis and the ways that they're supporting children and families, and the secondary and vicarious trauma that they might be experiencing. So how are we building supports into the culture of our workplaces to help retain those behavioral health clinicians?
And I think you're right about that. I think especially during COVID. During COVID was one of the times, because I managed a mental health clinic for Dallas ISD during COVID, and I had my staff, and it was the one time that they could say that they were experiencing similar things as the clients that they were serving. So how do you draw the line? And they had to show up, and it was okay to not be okay. And so one of the solution that I did was every Wednesday we had what we call our self-care group. And so that's where my team could show up as authentically as themselves. Because in order for them to give to the clients what I needed them to give, I also had to give to them what they needed to fill their tank. So self-care is extremely important in this work and making it intentional. And so for us, I made it intentional by this is your goal on your professional development goal. How are you taking care of yourself? Because if you're not taking care of yourself, then you don't have what you need to take care. It's that reciprocal process. I expect you to do this now. I'm here for you, and being intentional. And that's one of the things when you keep going and going and going so much, you're holding space for other people in mental health. You also need someone to hold space for you, and you also need to be in that space where it is okay to not be okay. It's okay to say, you know what, today I'm having a really rough day and I need to take care of myself. And for your job to be able to support the need and the importance of self-care for caregivers, because you're right, vicarious trauma can take us down. And unfortunately, when you get burned out in this field, you sometimes don't want to come back because it's so bad. So it's really important to take care of yourself.
I'll just add, like for bilingual therapists too, I feel like
Yes.
that is one of the biggest populations that we tend to burn out quickly because we have so few bilingual therapists. So like one, on the workforce front, how are we recruiting a diverse workforce that can meet the needs of the populations and the linguistic needs too that we see? And then two, how are we protecting their peace while they're working?
Well, and I would add, and how are we training them? Because I see so many systems, it's like, oh, you speak Spanish, go. And you get thrown in and to do this work, and no one's really taught you the clinical language in Spanish. No one's taught you what that therapy in Spanish looks like because you've been trained only in English. And so it's not just an easy switch on and then you can do this in Spanish. So I think we really overburden our trainees who happen to speak a second language. I think the other thing that contributes to provider shortages is also the way mental health is reimbursed and paid for. We have professions in the medical field where if I have a headache, I can go to the doctor before things are really bad and get treatment, and my doctor can bill for that without giving me some big diagnosis. That's not the case in mental health. So I have to have a diagnosis. I have to be now in a mental health crisis before I can get compensated by insurance versus I'm feeling a little stressed and therefore I want some treatment that maybe is only a couple of sessions, but insurance is not going to reimburse for that.
And that kind of builds on what I was going to ask Brown, but sort of a lot of young people only go into the crisis point when they get that treatment. So is it a point where the medical community is going to have to start helping out behavioral health a little bit more to kind of get us out of the situation?
Yes, yes. So while the work on the end of the workforce issues is happening on the ground, we're still faced with, okay, this is what we've got. It's not enough. How do we make it work for our kids? And so it really, I think that there is becoming more of an awareness of it takes all of us. So not just the specialists who work in mental health, but also my medical colleagues who work in primary care. And so that's one of the things that Children's Health has been doing, and in my work, and we're seeing programs popping up that are focusing on this collaboration between the two sides. And really the goal is to reintegrate mental health and physical health. We've sort of created this separation for ourselves that's arbitrary, and it doesn't really make sense because the two go hand in hand and they affect each other. And so sort of business as usual that we've often gotten ourselves into is that a kid goes in to see their PCP, and maybe they make a statement, and the PCP is like, that there might be something there. I'm going to send them to a psychiatrist. 6 months later, they're still waiting to see the psychiatrist because there's not enough of them, right? And so during that time, the kid is getting worse and not getting that treatment. And so it's about using our resources in the smartest way, I think. I don't expect or want PCPs to now be psychiatrists. That's not the answer either. But we do know that there is opportunity there when the issues first start to arise, to, like you were saying, let's empower them to start to have those conversations, to start to get them plugged into what they need before they reach the crisis point. And the work really takes all of us across different fields doing it together.
And that kind of mentioned the roles that a lot of these organizations are having to kind of determine for themselves over the past few years as the mental health needs continue to increase. But I guess one that has been changed a lot over the past decade is for teachers. They're tasked with doing safety checks, doing mental health checks, things like that. What do you, I guess, as educators, view the role of the school when it comes to mental health? And are we putting too much on our educators?
So one of the there is a statement from the tipping pain scale that I like to talk about, and it says the obstacle to treatment or engagement in treatment is not the absence of pain, but it's the absence of hope. It's not the absence of pain. We know there's a lot of pain, but it's the absence of hope. So what school mental health program does, it gives students hope that you can have a better tomorrow, you can have a brighter future, that you can recover from this. A lot of times when kids show up at the hospital, and why it's important for doctors and medical professionals to really look at trauma, relational trauma, it doesn't change the DNA, but it changes how it is expressed. So that's called epigenetics. So relational trauma is so important, and it comes down from generation. It doesn't have to be the child. It could have been the trauma that experienced by the parent that is now impacting the child that's shown up in the classrooms. And so it is very important for teachers, and even from the parking lot to the cafeteria person, to be aware of what does that child look like. Because when you see a child that has a behavior, so let's say the behavior, I'm fighting, that's just the tip of the iceberg. That's what we see. And when we look at the iceberg, we talk about it's not the tip that is important. It is important because that's what they're referred for, right? That's what they show up at the hospital for. That's what they show up here. But what is carrying the biggest weight is what's below the iceberg. It's that loneliness. It's the anger. It's the relational trauma that they've been through. It's the abuse. It's the death. It's all of those things. But if we don't stop to consider, is this child willfully being disobedient, or is this a survival or trauma response? We've got to start looking at behavior in a different way. And so school is a primary place. If we look at the fact that on an average, mental health illness starts at about age 14. Where's that? That's school. And I wouldn't be surprised if those ages are going to go much younger. based on what's happening right now. But if we look at the average age of 14, that is the school. So this is the primary place for students to start getting services, in a place where, because one of the things with Dallas ISD is the students don't have to leave campus to get support. So then that way they're not marked absence, right? That helps to decrease truancy. It also helps, someone says, oh, you go see a therapist? Oh, I've been struggling too. I've been feeling sad. Who's your therapist? How do I get that? So there's this support system that is in the school. We go out and we consult and work with not only SEL, but also the teachers and the school counselors to make sure that it takes that village to give that child hope. So if we want to make a difference in children's life, if we look at the adverse childhood experiences, it talks about that has a lifelong impact all the way from birth through death, right? So if we can somehow come in and impact the trajectory that that child is on, that means that that child, if we just change that for one child, that means that we've given a different life framework for that one child, right?
In the Momentous Institute, you guys have a very unique way of kind of approaching this. Can you kind of go into more detail?
Certainly. You know, our school, we have an elementary school, so pre-K 3 through 5th grade. And so we're integrating social emotional learning, mental health, social emotional health into the curriculum. So it's that preventative model. Like, and to your point, like, we do not expect the teachers in the classroom to be therapists and to navigate all of that. They do need to be supported because we've got teachers leaving the field just like we do mental health providers, but we're trying to infuse an awareness and skills for children at a very young age. So this is more of a preventative model where children are learning about their bodies, they're learning about their brain, they're learning how to do things that if I have a strong emotion, that may not be clinical depression, it may just be a strong emotion. How do I navigate that? How do I help myself regulate? How do I ask for help? And at the same time, it is not unusual for one of our students to be able to say, I think I would like to see somebody. I've been thinking about these things, or I've been having these really strong feelings. Can I see somebody? So that we're trying to destigmatize the need to see somebody while also infusing strength-based, positive, preventative skills as well.
And I just wanted to add one thing you said that I wanted to highlight, that the idea of the preventative care is so important, because it's not a question of if something is going to happen, right? We all are going to have things that stress us out. We're all going to have different hardships that come up in life. And so thinking about how can we help out kids and families right at the front end, teaching them skills, teaching them coping skills, building up that resilience beforehand, so that one, when something happens, they're better equipped, and two, when a kid is feeling that they're noticing that something's not right, it's easier for them to speak up. It takes a lot of courage for a kid to speak up and say, I'm not okay, not knowing how it's going to be received by the people around them. So,
and the one other thing I would add is we are super intentional about involving the family. Like, children do not exist in isolation, and so many of our systems, by virtue of just logistics and reality, don't get access like they want to the families. And without parents and caregivers being a part of the team, so to speak, it's going to be that much harder.
And we have about 10 minutes until Q&A time, which will be done by Matt back there, which you'll have a microphone. But I'm always a big fan of kind of wrapping these things up with some hope. So I guess from the overall landscape, what are some programs and things that are coming out that are kind of helping that people get some of these resources into the community?
Yes, I'm so glad you asked that. Because there's a lot of reason to be hopeful. The Texas legislature has invested a lot of money in behavioral health. I think in the last, let's see, I wrote it down somewhere because numbers, y'all. We've invested in some really great programs and a lot of fun. So it's like 100 billion. I mean, it's just a lot of money is being invested in behavioral health. And so a lot of this is going towards programs and supporting schools. So one of the things that my co-panelists have shared is the role of schools. And so one of the most important roles that a school can play is that early identification piece. So schools may not have the same resources that Momentous and DISD have. Those are really wonderful programs. They may not have those resources. And the most important piece is identifying the needs early. As we've talked about, early identification is key, and being able to connect students to resources that meet their needs. So the really important part is that connection piece. So whether that's a community provider or that comes into the school or a community provider outside of the school district, that connection is really important, because if we only identify needs and then don't do anything about it, we are contributing to this crisis that we're seeing. So one, there's that. There's also some of the funds that have been used are filling really critical gaps. So one of the things that we see very often is that there isn't a lot of intensive outpatient programs. So we have early intervention, we have hospital, there's very little in the middle. And so the Texas legislature invested in two really important programs, three actually: coordinated specialty care, which supports people who are experiencing early onset psychosis, multi-systemic therapy for children and youth with the most serious mental health needs, whose mental health needs are getting in the way and perhaps their success at school, their ability to function well in the community and at home. And then another program that we're launching in Texas is youth crisis outreach teams. And these are mobile crisis outreach teams that will be specific for youth. So right now we have mobile crisis outreach teams that are very specific to adults. And the youth crisis outreach teams, it's a pilot right now, so there are about 8 teams funded throughout the state, and one in North Texas. And we will be seeing more youth-specific crisis interventions. So hopefully this will reduce some of the emergency room visits for mental health needs, and we'll be able to intervene earlier and connect to really important services like coordinated specialty care, multi-systemic therapy, or other less intensive therapeutic interventions. So a lot of really exciting programs being launched.
And to kind of build off that a little bit, there's been a lot of discussion about some of the telehealth options that are being made available to students. Do you view that as maybe a solution for like rural communities?
Thank you so much. I should have talked about TCHAT. So for people who are not familiar with TCHAT, it's the Texas Child Health Access through Telemedicine. And every time I successfully say that acronym, I give myself a mental pat on the back. So that's what I'm doing right now. So TCHAT is a telehealth program also funded by the Texas legislature since 2019 that connects students to mental health resources through medical schools in their region. And so to licensed mental health professionals. So they're able to access short-term mental health supports, which often serve as a bridge to longer-term community outpatient resources. And so this really is great for rural areas because they're able to connect in ways that they just can't because of proximity, the rural nature of care. So they can get telepsychiatry, counseling, just many different services, evidence-based, that can make a difference. And this is available to every school district in Texas that wants it. So they have to opt in, but it is funded by the Texas legislature, so available to every school district. Every child in Texas has access to TCHAT through their school. And I know, Sabrina, you've worked with TCHAT and CPAN, so I don't know if you have anything that you want to add about that.
Yes, before I did my current program, I worked with those programs too. And I think that whenever we can increase those access points and get to places where kids are, and the telehealth options, to your point, even in my clinic, I do telehealth, and it makes it so much easier for parents because they're not maybe having to take that long drive, taking less time off of work, because as a psychiatrist and also counselors, we're seeing the kids a lot more frequently than their other physicians. And so it can be tough. So that really does make it a lot easier for families to access. And I will say, just as far as programs and things, my particular program, the Behavioral Health Integration and Guidance, we launched a couple of years ago with a pilot group of PCPs that we trained in recognizing and identifying, managing mild to moderate behavioral health issues. And we also provide them with ongoing support in managing those things, in triaging, getting kids to the right level of care, and starting treatment for those that it's appropriate to start treatment for. That program has picked up a lot of interest. And so we've gone beyond our pilot program. We have trained several groups, not just in Texas. Now we've spread outside of the Dallas area, outside of the state, and now we're in states in different parts of the country. And so I think that really speaks to, within the medical community, there's been a lot of talk about collaborative care is one of our favorite phrases, but how do we integrate mental health back into the medical home so that it's all a one-stop shop and we're making it easier for families to get all the care they need? And so that is a conversation that we, in my personal work, I'm seeing, but it's happening across the country. Big institutions are having those conversations. So there is hope.
Can I ask you a question, Sabrina? So I know that when you use the collaborative care model, which is what you're using in Big, that it can increase psychiatry, because we know there's like child psychiatrists are really hard to get into. So by using it, putting it into primary care in the way that you're doing through this initiative, you're increasing psychiatry time. Is it by like 8 times? Like
Yes.
You can serve like 8 times as many people?
I'm so glad you brought that up. So yes, but one of the things that has been amazing for me is it has really expanded the reach that I can have just like individually. I do see patients individually, but if we estimate that each pediatrician has on average like a 2,000 patient panel for each person that we train, that's potentially 2,000 people who have now more ready access to mental health services. And so that's been really exciting for us. The number I think we've trained, and I'm going to get in trouble if the number's wrong, but we've been, the numbers have been ticking up. And so that part is exciting. And then the other thing that I think is important to keep in mind, just from the medical system, is that when the PCPs do feel comfortable and empowered to manage those milder cases and sort of, hopefully stop it before it gets severe, that opens up the end for the specialists like myself to see the really severe cases a lot faster. So they're not waiting, months and months trying to get in to see someone and just getting worse and worse, because the longer we see them in that state, the harder it is to get them back to where they were before.
Well, thank you guys. Thank you guys. It's been a wonderful discussion so far. I kind of want to open this up to Q&A at this point.
Before we do really quickly, can I just talk about briefly the framework for Dallas ISD?
Yes, that'd be great.
Okay, so one of the good things about us is we have a really comprehensive program to add to it, and we also provide psychiatry services. So that's one of the good things. So students that need medication management does not have to leave campus to get that. So we have both a school services where we have fully licensed clinician, LPC, psychologist, LMF, licensed marriage and family therapist that go onto the campus, but we also have 13 youth and family clinics. So that's where we have the higher level of care where you can get individual family therapy, group therapy that's also offered. And so we try to provide as many services through those programs. We also have an alcohol and drug prevention program. So intervention is really good as well. So a lot of our drug and alcohol program is about education and prevention because it is so much more expensive for intervention.
Great. So as we enter into our Q&A, we have about 10, 12 minutes or so for questions. For those who are joining us online, you can ask questions at texastribune.org/ask. And for those in attendance, you're welcome to come on up here and ask a question. I'd just ask respectfully so that we can get to as many questions as possible. You try to keep your question relatively concise. As we get started, and Dr. Perch, I think you may have referenced this, one of Dr. Murty's findings, but particularly around the loneliness epidemic, and that in adults, 1 out of 2 American adults, but as a parent of a boy, I also know that there is a particular challenge right now, both with men and boys, and this is for anyone on the panel. How are you all seeing this play out? What are some strategies right now in addressing this, particularly, as we talk about young people, that's up to those who are now in post-secondary school?
I mean, I think especially with boys, it's continuing to talk about, giving boys language for their emotions, women and girls just have more words at earlier ages in life. And, when boys talk about their emotions, it's like I'm either happy, sad, or angry. And they just don't have a range often because it's not part of our culture to really encourage that. So I think that's one, is really trying to normalize talking about emotions that are varied, and continuing to support boys to ask for that help. Boys are also spending a lot more time gaming than girls are, and so really I think it's and I know I sound like a broken record when it comes to some of these things, but really monitoring and thinking about how much time are they spending in those platforms, which ones are they spending time in, because some of them are much more aggressive and violent, and who are they playing with. When you think about, are they playing with strangers? Are they playing with people that they have a relationship with already? And encouraging that, but it also encouraging that time away from, and that those interactions with each other face to face. But I think we have got to normalize for boys the same way girls tend to really be much more open about talking about sadness or anxiety, that this is something that we all experience, and that the more we hold it in, the more we keep it quiet, the more we don't speak about it, the bigger it grows. And that's often what we're talking to kids about, is speaking about it diffuses it. It makes it smaller, just naming it and saying it out loud.
And I think the more awareness we have about mental health illness and that it's okay to not be okay, we're hoping to move away from the idea that real men don't cry, right? Because that's how a lot of us was raised. You're a man, you need to tough it out. It's okay. In sports, you play whether you're hurt or not. You just do your business, right? And so we have to recognize that boys, they also need connection, because that's the one of the biggest thing that we all need in life, is to be connected and to feel loved and valued and appreciated and have someone who believe in us. We have a young man that this just happened yesterday, and one of the staff was teasing him, it's time to discharge you. And he's like, what? No, I can't, because this person that was working with, he considered him a role model for him. That's someone who gave him words to understand what he's going through and how to deal with life challenges. We have to understand, not only does girls need that, do the girls need that, boys also need that opportunity to connect and to have, like you said, a voice. That's what they need, is how do I use my voice in a way that is not angry or not pompous, but compassionate and kind and loving, and that is okay for a boy to be all those things.
I'd just like to zoom out real quick on that answer. So one of the things that you mentioned was both post-secondary and the Surgeon General. And so the Surgeon General, I really appreciate his messaging around loneliness and calling it an epidemic of loneliness that we're facing. And that spans the lifespan. So he's not just talking about children and youth, he's talking about adults, about older adults. And so that requires a public health approach. And a public health approach requires all of us. And so it's not just the schools, it's not just primary care, it is culture and well-being. And so one of the things that I appreciate about post-secondary institutions and and I know that happens a lot in K-12 as well, but one of the big pushes is around wellness and belonging. How are we creating spaces where people feel like they belong, and that sense of belonging brings you connected to your community, supports your mental health, supports your success.
And looks like we have a question in person.
Yes, I actually have 3 things I wanted to highlight. My name's Dr. Denise Wooten. I'm a licensed psychologist, been in private practice for over 30 years. And so Dr. Vogel and I know each other previously, and so we were chatting beforehand. And the issue of insurance reimbursement is a very big one. I had to personally get off of Medicaid because I was losing money, and some other insurance providers. So there's been a phrase in our field, mental health parity, when it comes to insurance reimbursement, and I think that needs to be investigated. Why can't we do well child checks and catch some of these things earlier? Why do we have to wait till somebody is very much in crisis?
And not to mention the administrative burden of taking insurance in the first place. So.
Right. And then the baby boomers are retiring. So it is not just that this is a difficult field, it's that we have a generational problem when it comes to mental health providers. So if we're going to attract bright young things to our field, I think we need training incentives It takes a lot of money to turn out a mental health professional, even at the master's degree level. And so if we don't incentivize that training somehow and make it more affordable, we will continue to have a shortage. And then my third thing I wanted to highlight was, I hope all of you are directly lobbying somehow with the Texas legislature. I hope you have those connections. I hope you're able to figure out which of the representatives and Texas senators are responsive to mental health. And I think we really need to target mental health. That ought to be a bipartisan issue, y'all.
I will say that mental health has been a bipartisan issue and is part of the reason that we've been able to increase the funding pretty significantly for mental health services. And you're not wrong about all of the things that you just shared. So reimbursement, we continuously hear that from providers about why, and contributes to the workforce shortage and the inability to actually get into services. So how do we reduce that administrative burden? How do we talk about reimbursement rates? And then when you were asking about or talking about training, it reminded me something I should have said earlier. But Governor Abbott really recently directed the Higher Ed Coordinating Board to develop a task force to examine healthcare workers and increasing the workforce around healthcare, of which behavioral health is one of those. And so that is looking directly at training programs, looking at recruitment. So how do we recruit to kind of fill this gap that we'll see when the boomers retire? And then you're kind of proposing some of those more systemic workforce solutions for the behavioral health field. So again, on a hopeful note, I do have hope that there are some solutions coming.
And I think just one second, I'm sorry. I think there are many schools that may not have the capacity or the funding to have a comprehensive program like Dallas ISD has in this moment. But you can utilize your community resources. There are community resources out there that want to partner, because not only there are too many students in Dallas ISD. We have about 146 clinicians. So without our community partners, they help to expand the work that we do, including we had T-Chat for a little bit in Dallas ISD as well. So if you're not able to offer all the components that we have here, you could start somewhere in your community and make sure that you align and collaborate with the drug and alcohol programs out there. There are programs out there, Children's Medical Hospital in different places that you can align with. So start small and then grow big.
And it looks like we have a question right here.
Hi. First of all, I want to thank all of you for your contribution to hope for young people in Texas. It's something that's close to everyone's heart in here, I'm very sure. My name is Phyllis Jones. I'm a PhD psychologist, and I've worked for years with the Department of Family and Protective Services. And I've watched over the years as there's been kind of some articles in the paper, with the different kinds of challenges that the department has struggled with. And I'm sure you know that privatization just took place, right? And that's been very, very challenging to try and have a continuation of services. And in many instances, it just completely fails. But I guess one of the main issues that I have related to what you're talking about that I have noticed is that a number of parents who are involved with the department, they don't have medical care. They don't have a PCP. I've worked with so many that had cancer and they just never got it treated. They had very serious diseases and there was never any medical care. They worked with, the social workers, with the department, but, they failed many times. And so the children of these parents often cannot get connected to a psychiatrist. There's a shortage of therapists right now, and I'm sure you know this, that the reimbursement for therapists with the department has declined this year instead of going up. And that's not a very good incentive for retention. And so my question is, how do you see what your talking about in terms of all of these wonderful developments, how do you see that these parents and children can gain more access to these amazing services? Thank you so much for your question.
Well, I'll just say first, thank you for the work that you do, because that's very important and also very challenging. I'll see if you all have anything to say before I can jump in.
Well, I mean, and it's there's no easy answer, right? And at Momentous Institute, we do have a school. We also have an outpatient mental health clinic and have partnered with DISD and other schools, and that's one of our missions, is to be sure we're allowing access to care as low barrier as possible. We don't mess with insurance. We have bilingual providers. We don't have zip code requirements. If we can provide the service to you, then we will. And we won't turn anyone away for the inability to pay. So, and we have a very generous or unique funding source through the Salesmanship Club of Dallas and the Byron Nelson Golf Tournament. And so we're small, but, it's us. I think it's what we've talked about is this collection of nonprofits that will allow for access. We really just try very hard to make sure parents are incorporated into our services. So if a parent needs mental health services, we're not referring them out. We're treating that adult as well. I know you're speaking about medical care, which, we do not provide, but you may have larger system kind of solutions.
I was going to say, for us, what we do is we do partner with several physical health partners in order to be able to provide the systemic approach, because we want to rule things out and figure out what's going on, what's the root cause. And so in order to do that, we have to align with community partners. So that's why it is so important to find out who's in your community and who's available for partnership in order to be able to do that. We also is thankful for our upper leadership and our trustee who have afforded us the opportunity to be able, because there's a times that we're on campus and people don't even know that we work for Dallas ISD because it's so different for other school districts. We're all of these things that I mentioned before is part of Dallas ISD itself. And so we have a unique situation, but we couldn't do that without our community support and without our upper leadership.
So I just want to acknowledge, one, broadly speaking, we as the royal we are not doing right by these kids and families who are part of the foster care system right now. And I don't think that falls on any one entity or organization. It's a challenging issue that we all have to manage and support together. And so this requires a lot of, in my opinion, my humble opinion, this requires a lot of coordination and collaboration and reducing some of the systemic barriers that get in the way of supporting kids and families in the way that they need to be supported, particularly if they've been part of the foster care system or engaged in the child welfare system in any way. And I do have hope, so trying to end on a hopeful note here. I do have hope. There is a lot of work happening in this space to really try to better support children and families. So it is not unnoticed. It is a complicated problem and there are complicated needs. And there are no easy solutions. Just to give some hope, one of the projects that we've been working on recently is with the University of North Texas at Dallas, and they've wanted to improve the way that they support students who are formerly part of the foster care system. And we know that these students have tuition waivers. One of the things we learned is that often young people don't know that they have access to these tuition waivers, so they're not even getting there. So one of the things, and UNTD wanted to really support these students and help make sure that they make it all the way through. So we did a project. We worked with some of the students. We found out what some of the barriers were, and some of it was that they didn't actually know. So how do we make sure that these young people know about these really life-changing opportunities that are available to them and help support them in accessing them and moving through. And through this work, we got to talk to a lot of really wonderful young people and not just youth who are formerly part of the foster care system, but we talk with young people all across the country. And I have hope that this is when people ask me what gives me hope, it is the young people who are telling us what they need, who are more than we ever have before. So this generation is giving me some hope.
And I would add that the Children's has the Reese Jones foster care clinic, where it's both medical and mental health treatment that they have access to. So,
The children, but they're
Yeah.
not their parents.
correct.
Yeah. And the great hope for me is that our children will not have to struggle and wait 11 years from the onset of an issue to the time they receive services. And telehealth is now available so that can reach. So parents who have issues with transportation, let's go virtual. So that is the great hope, is that with all the services that is coming out and the ones that can be available to these families, is that we can start seeing that number go down, because that's when we know that we're starting to raise healthier children, right? And that's the goal. We want kids that are academically and mental health, that they are in the best, that we're giving them the best tools that they can have to be the best versions of themselves. So that's the great hope, right?
All right. Well, I just want to say thank you to all our panelists right here, and I want to say a personal thank you to all in the audience. As a person who went through most of his life with undiagnosed anxiety and depression, even though my own mother was a mental health therapist, because I was ashamed, it's encouraging to see such a diverse and I guess just overall all age groups coming out here to look and learn more about mental health. So I want to thank you guys for showing up, and I want to thank our panelists one more time, and hope you guys have a good rest of the day.
Thank you.